Okay, so welcome everybody once again to our March 19th Food Allergy Nursing Association educational speaker series with Dr. Michael Pistiner. I will be sharing my screen so we can introduce our guest, and he'll talk to us about food introduction and allergy prevention today. And Dr. Pistiner is the Director of Food Allergy Advocacy, Education, and Prevention for the Mass General for Children Food Allergy Center. He has special interests in food allergy and anaphylaxis education and advocacy, infant food allergy management, healthcare provider education, as well as facilitating collaborations between the medical home and school health and maintaining quality of life in children and their families with food allergies. He's also a fellow at the American Academy of Pediatrics, where he is a member of the Section on Allergy and Immunology Executive Committee, Council on School Health, and the Massachusetts chapter of the AAP. He's also a member of the American Academy of Allergy, Asthma, and Immunology and the American College of Allergy, Asthma, and Immunology. He also serves on the Medical Advisory Board of Asthma and Allergy Foundation of America, New England chapter, and is a voluntary consultant for the Massachusetts Department of Public Health School Health Service Unit. And he is also an author of Everyday Cool with Food Allergies, and co-author of the Living Confidently with Food Allergy Handbook, and a co-founder and content creator of allergyhome.org. I'm going to stop sharing and I'll let Dr. Pistiner share his screen to go over
Right.
content.
So, in summary, I really like teaching people about food allergy and I'm really into it. And one of my favorite things to do is to teach people how to teach other people. And so, what I'm hoping some of the language that I'm going to use here is many of you guys are masters of this content already. And so, some of what I will be passing along to you guys is going to be for you guys to think of teaching points that you're going to be having with your patients, whether you're in primary care or whether you're in allergy. And you're going to see how each of those is so important and so relevant. And what I'm assuming and hope is that whether you're in primary care or whether you're in allergy, you'll have the opportunity to teach the primary care teams who are working with you when you're on the allergy team. You'll be teaching your patients, but you'll also be teaching your teams. So the clinicians that you're working with, I'm thinking that there could be some training that's going to be going in the opposite direction from traditional. And actually, I'm guessing it because there's a lot of like old school folks out there that need a little bit of tightening up. So with that, let's get going. Um, Here's my disclosures.
Would you mind to share your screen, because I don't think we're
Oh yeah,
seeing.
I think it's only going to work that way.
Thank you.
All right. Let's make sure I got the right one. You have full screen here? Okay, wonderful. All right. All right, so back in 2000, the American Academy of Pediatrics released a statement that suggested delaying the introduction of highly allergenic foods. As we all know, that was a mistake. It's a myth that delaying the introduction of food allergens is protective. Now, it's been years, but people are still having hesitancy in being able to support and educate families and communities about early introduction. But while we're figuring out how to best approach it, the babies just keep being born. They just keep coming. And people keep delaying, despite good evidence and good attempts at improving some of the education of early introduction. You are perfectly positioned to be able to help support these families in introduction. and to get around some of the barriers. So the hope that I'm having today is that after this, you'll feel quite confident in your approach. Now, these are complicated conversations that we need to be having, whether it's in primary care or whether it's in the allergy clinic. And these conversations are going to be different from one family to the next. So shared decision making is going to be really important in figuring out what's going to work for each of the families right in front of us. Now, as we all know, these types of decisions take a lot of time. And in primary care, there isn't a lot of time because you have to be talking about vaccines, firearms, car seats, trampolines. Who's going to have time to talk about introduction? And we've seen some of these after visit summaries from the well child checks when they say, introduction discussed. But that's where in the primary care setting, you have the opportunity to be able to support those families right then and there, and in the allergy setting as well. So the goals of this talk are to help you advise against delaying introduction of highly allergenic foods, to encourage shared decision-making conversations with the families that you care for, and to help understand the available guidance that's pertaining to the prevention of atopic disease and how to use it appropriately for the kid in front of you. And so a lot has happened in the last 2 decades. And multiple guidelines, reports, and statements have come out. Trying to figure out how to put it all together can sometimes feel a little bit like putting together a puzzle. And it's not a one-size-fits-all kind of thing. And you have to go at a puzzle with a plan and with strategy. And that's the only way we're going to be able to do it for the individual child who's in front of us. A cookie cutter approach isn't going to work. Now let's go back in time to when the American Academy of Pediatrics withdrew those recommendations to delay. They did this in a clinical report. They said there's no reason to delay beyond 4 to 6 months of exclusive breastfeeding. And there's no evidence that that's going to be helpful. But it was passive language. They didn't say do feed, but they said don't delay. Then in 2015 came definitive evidence that early introduction is protective, specifically to peanut. The Learning Early About Peanut LEAP study, many of you are very familiar with this. This was the first randomized controlled trial to show definitively, as I was saying, that early introduction of peanut is protective. They had high-risk children who had either severe eczema and or egg allergy and divided them into 2 groups, the eaters and the avoiders. And the eaters ate about 2 grams of peanut protein 3 times a week until they were 5. There was 80% reduction in those that ate as compared to those that avoided. And since then, this has shown to be durable impact, that even as adolescents, there's a 70% reduction in peanut allergy, and those kids even could have done whatever they wanted after age 5 as far as eating peanut. So this really works. And so this study, we use time and time again to show that early introduction, at least of peanut, is protective. Now, there was another randomized controlled trial done on younger kids. They were about 3 months of age, and they had early introduction of multiple allergens sequentially. And this was actually in an age group that is younger than current recommendations and younger than when we are asking for exclusive breastfeeding or using formula. But encouraging evidence came out of this group in that there was no negative impact on the duration or impact of nursing. There was some improvement for peanut and egg in the kids who could keep up with the quantity of their goal. Their goal was 2 grams weekly of peanut egg, or the other allergens. But in the babies that actually were able to eat per protocol, enough egg and enough peanut, there was impact. Now, similar data exists for egg as peanut, but it's not quite as impactful. Meta-analysis has shown 30% reduction in egg allergy, and in many babies, they may be egg allergic early. So guidelines don't yet, at least the American Academy of Pediatrics, have not released guidelines, and the NIAID peanut guidelines have not yet been updated to include egg. But a consensus document, as I'm going to speak later to, does recommend early introduction of egg in addition to peanut because this evidence is so good. Dairy, cow milk protein, also seems to be protective. There was a randomized control trial done in Japan where about 10 cc's daily introduced at around 1 to 2 months of life and kept going decreased the risk that these kids developed a cow milk allergy. We'll talk a little bit about other data that also was done in Japan that showed that in newborn period, if cow milk-based formula was started and then discontinued without being continued, that was potentially risk. And we'll talk a little bit about the implications in the newborn nursery. Then in 2017, the addendum guidelines for the prevention of peanut allergy in the United States were released based on the LEAP study. But as the title tells us, it only applies to peanut. Now, these guidelines, I'm going to go quickly through them because they were introduced into the dietary guidelines for Americans, and that's kind of where I'm going to want to slow down our conversation. But these addendum guidelines for the prevention of peanut allergy in the United States, they were released in 2017, and they've been difficult to implement. They include a screening step for the high-risk kids, the kids who have severe eczema or already an egg allergy. Now, it applies to less than 5% of babies born in the United States. But with that screening step, it has put really intense strains on our system. And for many of you who are in allergy offices, access for babies and food challenges for babies is challenging, and wait times can be long. And by adding a screening step that might involve allergists and oral food challenges, we might be delaying the introduction in these kids by trying to follow this screening step. And in primary care, you guys might be a little nervous to just go ahead and introduce while the kid is young. You wait to send him to an allergist like me. My next available is August. That kid is driving by the time they try eating peanut. And so we might be losing a good opportunity. So these guidelines are right now being looked at, and people are trying to see if that screening step is something that we may need to give a little bit more flexibility on. Now, the sheer majority of babies don't need a screening step. And by the way, the addendum guidelines say that if the baby does have severe eczema or egg allergy, then we're shooting for between 4 and 6 months of life to get peanut in that kid or to commit to that kid having a peanut allergy, right? So think about it. How many times in your allergy offices do you actually have time to do an assessment on this kid before that window of 4 to 6 months of life? Lots of these kids are much older by the time they show up for your evaluations. And so this is the part where primary care, you guys want to be thinking about this when this baby is teeny weeny to get that kid on the schedule, to get them to the allergist. So the family can actually feed between 4 and 6 months of life, if allowed, if you're going to be using the screening steps. Now, in the kids that have mild, moderate eczema, then no screening is necessary. This is where in primary care, you guys want the confidence to be able to pass this confidently to the family. Go, go, go. Feed, feed, feed. We'll talk a little bit about those families that have we'll talk a little bit about those families that have a kid with like moderate eczema, but feel confident about early introduction in these kids without screening. Now, the guidelines themselves now say in a kid with moderate eczema, then you're going to want to target around 6 months of life. They don't have that 4 to 6 months of life because they want to respect exclusive breastfeeding. So that's why you have where you have the science of the randomized controlled trial of LEAP saying 4 to 6 months of life. The science isn't quite the same for the kid with moderate eczema or other risk factor. So that's why in these guidelines they give more flexibility for a little later. So as I was saying, this is most of the kids. So most of the kids can go ahead and feed. But now, family history sometimes can make some families a little nervous about it. But family history is not a reason to screen. And so this is one thing that you could definitively pass along to your colleagues is that if, and your families, if big brother has a peanut allergy and now little baby is about 5 months of life, go for it if baby skin is good and there's no other risk factors. No reason for screening, no reason to see an allergist. You could save that allergist schedule by having the baby not go to the allergist. And they could check in because of Big Brother and just say, hi, we congratulate us because we had a baby, but then they could go ahead and feed. And you want that slot on that allergist schedule to be for a kid who really needs it. All right, so though those guidelines have been baked into now the dietary guidelines for Americans, and we're shooting for 2 grams of peanut protein 3 times a week. That's about 2 teaspoons of smoothed out peanut butter. Careful, no loose nuts until after age 5. And you want to smooth out that peanut butter because it's a choke risk in itself if they just go straight up off the spoon. Now, reactions are something that many families are nervous about. And there's a lot of reassuring data here that in the LEAP study itself, very, very rarely was there a reaction, a significant reaction. And when the babies entered the study, there were very few systemic reactions. But now at age 5, that was when there were actually significant allergic reactions and more systemic reactions in the older cohort. So when they're young, it does seem, and the anaphylaxis practice parameter do support that rarely is the first introduction going to be anaphylaxis. We do have some data that anaphylaxis happens, but it's rare and it's kind of an oxymoron. Mild anaphylaxis, right? Anaphylaxis is anaphylaxis, but it's rare for the babies to have the severe, scary anaphylaxis that we see in our older kids. So now, since then, 2019, the American Academy of Pediatrics released a report, which again supports the early introduction of peanut and those guidelines. But now further, they say that there's no evidence supporting maternal dietary restrictions during pregnancy or lactation. So no reason for a mother to discontinue certain allergens in their own diet. They say there's a lack of evidence that hydrolyzed formula prevents atopic disease. That used to be a recommendation, but then remember the caveat that I just said. The newborn baby where formula is going to be introduced, but the family doesn't want to continue, that might be where we start having conversations about the protection for dairy allergy with cow milk based formula that is going to be introduced and stay on. But if someone is adding formula with the purpose of discontinuing, just getting a hyperbilly baby through a dehydrated period to be able to then get them to exclusively breastfeed with no reason, with the family with no interest in continuing on a cow milk-based formula, that might be a role for hydrolyzed formula. They also, at this point in time, said again, there's no reason to delay introduction of allergenic foods beyond 4 to 6 months of exclusive breastfeeding. They also have some nice data in there supporting breastfeeding and its advantages for atopy prevention and wheeze, although breastfeeding has not been shown to have impact specifically on food allergy. So now in 2020, the USDA and HHS released the dietary guidelines for Americans. A lot of people aren't familiar with this. If you're not familiar, get familiar because they're fantastic. These are holistic. They approach the whole breadth of nutrition, not just peanut allergy. And they are nice to be able to put in the hands of your family. They have nice PowerPoint slides that you can use. These are PowerPoint slides that are meant to be shared and meant to be presented off of. So go back to the site, check out my references. I'll have a link at the end. And if your teams don't know about these, then share them with the entire team. And it's really easy to have some of the conversations about early introduction if you springboard off of these. So with that, the dietary guidelines for Americans say, think about complementary foods at about 6 months. Complementary foods are important because they're going to help the kids get used to certain flavors, textures, and developmentally, it's great to practice. Now, some infants may show developmental signs of readiness before age 6 months. But introducing complementary foods before age 4 months or waiting until after 6 months is not recommended. So wrap your head around that. They're saying don't start before 4, but don't start after 6. And now I'm going to keep coming back to this. I'm going to be a broken record, but you'll see why. And it's kind of exciting. And it's like, this is what we need to get people fired up about introduction. So for infants fed human milk, it's particularly important to include complementary foods that have zinc and iron, peanut being one of them. And then we'll want developmentally appropriate foods to decrease the risk of choking. So while I'm talking about like the tree nuts, sesame, then thinned out tahini, thinned out nut butters, things like that. That's what we're talking. Again, no loose nuts. So the guidelines say there's no evidence that delaying introduction of allergens beyond when other complementary foods are introduced helps prevent allergy. Got that? So now they're saying, as far as allergens, you don't need to delay them beyond the other complementary foods. And remember, the other complementary foods, don't start them before 4 months, but don't start them after 6 months. So now we're in this kind of tight window, right? So foods like peanuts, egg, cow milk, tree nuts, wheat, crustacean shellfish, fish, and soy should be introduced when other complementary foods are introduced. So share this with your practices. Now, we were already talking about peanut, so they are exactly cutting and pasting from the dietary guidelines for Americans. From the addendum guidelines for peanut. So they bring those into these. And they also say that a screening step may be needed, but talk to your pediatrician. So there's still a couple missing pieces to the puzzle. The dual exposure hypothesis. Skin is the sensitizing route. The gut is the tolerizing route. So if a baby is coming in contact with, let's say in this case, peanut or tree nuts through the environment, through their skin, then antigen presenting dendritic cells of the skin, especially if there's eczema which causes barrier dysfunction and inflammation. These antigen-presenting cells that come in contact with food allergen on the baby's eczema may skew the kid towards sensitization, towards the development of food allergy, where if they have the opportunity to eat it and it comes into their gut, T regulatory cells can chill things out and it skews the kid towards tolerance. So now imagine this baby we got over here, and big brother and big sister are eating nut products everywhere all over the house. The kid is naked and rolling around. This kid is going to be coming into contact with environmental, in this case, peanut. Now think about the baby with eczema. I'm the dad. I just ate my cashew nuts and I clean my hands like anybody after I eat my nuts. Baby wakes up from a nap. Now I cuddle with baby on my chest that has my cashew nut dust. And now I put the Eucerin on the baby and mash my cashew nut dust in the baby's eczematous skin. Then I do a diaper change, mash it in there, put on the Desitin, and then I wash my hands. And so this is something that we may want to be able to communicate to the families. Hey, before you handle your baby's skin, especially after you eat foods that your baby doesn't have the opportunity to eat, wash your hands. So additional information, our team collaborated with Corinne Keat and Hopkins on a study that's literally called Age and Eczema Severity, but not family history, are major risk factors for peanut allergy in infancy. So the title alone tells you what we showed, and that's worth passing along to your families. And so what we found was the older the babies, when we're talking about from 4 to 11 months of life here, right? So the older the babies, the higher the risk when you are introducing peanuts. So the longer you delay, the more likely the kid is to have a peanut allergy. We showed that family history was not a risk factor, and severity of the eczema was a risk factor. So the worse the eczema, the more likely the kid is to then have a peanut allergy. And so these were kids who were naive to peanut when they were recruited. And so then we were looking at the likelihood that they then would have a positive peanut challenge or observed introduction. So among infants with moderate to severe eczema, older age was strongly associated with increased risk of peanut allergy. And eczema severity also was associated with increased risk. Now, in a kid less than 6 months, they had about 18% chance of already having a peanut allergy. But now if you let that kid get older, between 6 and 8 months, look at the way their risk increased. And then the 9-month-old almost has a 50-50 shot of being positive to peanut. So every month that you delay could increase the odds by like 30%. So that's where if someone wants to follow the screening step, you got to make sure that you're going to capture that kid young, because just by adding those months, you then increase the chance that, yeah, they might make it to the allergy team, but then the allergy team then says, hey, we got to put them on the list for the peanut challenge. So then after they waited 3 months for the allergy team, now they wait another 3 months for the peanut challenge. Of course they're going to fail. But if you just introduced early on when that baby was 5 months, then chances are that kid would have passed. And even if they had a reaction, not going to be that bad. So now there's some workarounds. The Quad AI and the college and the Canadian Allergy Society released a consensus approach to the primary prevention of food allergy through nutrition. Now, this has been out for a couple of years, and it works away the screening step, and really encourages the introduction of not only peanut but also egg and the other complementary foods and allergens. And so this is a great document. The challenge here is, what does the American Academy of Pediatrics support and then share with their viewership? And so this is going to be where teams are going to need to look at the fact that there does need to be updates in current guidelines, and this is what we have available. And thinking about where you are and your access is going to change what you guys do, right? If you have an allergist who can do a challenge tomorrow, might as well go get screened and then do the challenge. But if it's going to delay things by 5 or 6 months, then get the show on the road. And so that's where thinking about your timing, your resources, and your collaborators is going to really help in what the approach is going to be. So other countries, we're the only country with a screening step. Australia, Israel, UK, they're all just early introduction without screening. And there have not been reports of bad outcomes. Now, another piece in the puzzle, as I was mentioning earlier, relatively recently was the release of the update of breastfeeding and the use of human milk, where the recommendation now, and that's from the American Academy of Pediatrics, is exclusive breastfeeding for approximately 6 months after birth. Appropriate complementary foods introduction at about 6 months. But then they write in the addendum guidelines for the prevention of peanut allergy and then say, well, you can actually go younger if it's peanut between 4 and 6 months of life. It's a little challenging because of the dietary guidelines for Americans saying that window. And so this is going to be where shared decision making with the families is going to have to come into play, where when we're thinking worldwide about babies saved from diarrheal illness and malnourishment, then exclusive breastfeeding until after 6 months really does make a lot of sense in a family with risk of food allergy, and malnourishment is not something that they themselves are concerned about. Then being able to work with them and participate in shared decision making to decide when is the right time to get it in this baby is going to make a lot of sense. And so this is putting the puzzle pieces together, is that shared decision making component. So we could share what we know, we could share what we don't know and the uncertainty, and then we can narrow the gap of knowledge between our families and us. And that's going to build trust and empower them and empower our teams. And so we'll want to be able to address the barriers and concerns that each of the families may have. We want to be aware of the access issue and try to, and again, I think that you guys are going to be part of the solution, is that if, whether it's in primary care or allergy, we build in time for training, then it's going to be able to, we'll be able to get at some of those shared decision-making conversations. But if a clinician has literally 30 minutes to do evaluation, management, skin testing, talking about auto-injectors, talking about anaphylaxis, epinephrine, are they really going to be able to talk about advancing that little baby's diet? It's going to take a lot more time than that. So that's where building in some of these conversations is going to be really important. And as a reminder, the babies keep coming. Here they come, coming. Dr. Google's going to help them if you don't. And so our goal is safe introduction without delay. Please check out FAMPIT, Food Allergy Management and Prevention for the Infant and Toddler. We're in about our 5th year now. So my team has been working on clinician support tools. This is meant for primary care. This is meant for nurse practitioners, PAs, MDs, DOs. This is meant for pediatrics, family medicine. And then we also have resources for the newborn nursery. We also have resources for WIC. And so there are family-facing resources in English and Spanish, but the site itself is meant for the clinician, and it has different tools for clinician education, but then also family education. Thanks for having me. And then here are additional resources.
Thank you, thank you, thank you. I do want to open up to questions, and actually, I put in the chat a couple of resources that Dr. Pistiner shared with me, that which are now part of FANA's website as well, so everybody can access them, especially if you're already logged in into a member portal, and they're also available through the website, outside website. So I don't know, would you like to talk a little bit more about those tools, just so people know what they are and how to use them?
Yeah,
I put them in the chat
are
also.
those the anaphylaxis?
The flow sheet template.
Yeah,
And okay.
neat. So, other than being obsessed with early introduction, I'm also obsessed with infant anaphylaxis. And so, trying to help improve recognition as babies can't tell you that their mouth is itchy. And as we know, babies also are really sick when they have low blood pressure. And so, relying on that is not going to be enough. So, one of those tools is the modified criteria for anaphylaxis, where we offer a modified criteria for earlier pickup of anaphylaxis in babies. And so one of those is a manuscript published in Jackie in Practice. And then the other is a infant toddler allergic reaction anaphylaxis flow sheet. So in your practices, you can load it into Epic. If you have an Epic team that would, we actually have a recipe in there, so you could give it to the data support team. And please use it. We're hoping that people would then be able to compare data. And if you're going to use it, it would be awesome if you just let me know so we know how it's going and if it's working or not. Now, in its most beautiful form, it would be a flow sheet template where you would be able to document at each time point during the OFC or the OIT updose or omalizumab administration when you're documenting the reaction. But it can be simplified, so you could turn it into paper where you summarize at the end all the signs and symptoms, and it helps categorize their behavior. So, like mental status change in an infant, how do you tell the difference between that and a wet diaper or hangry? And so that's where these two resources hopefully are going to help you guys think about and approach allergic reactions and anaphylaxis in the infant.
Thank you very much. I would like to open up to the questions, if that's okay.
Please.
Thank you. All right, so if you guys want to raise your hand so we can, or put your question in the chat if you're camera shy. That was fantastic. Ali, go ahead.
Hi, I'm Allie Dappa. I'm a food challenge nurse at Mount Sinai. Thank you for your talk. My question is about the cow's milk formula because I find even just anecdotally with friends, they might not even know their baby had cow's milk formula in the nursery, or they did it one day while the mom was traveling, and it's not really advice that we give out to keep the cow's milk formula in the diet. So I was just wondering how you kind of navigate that and which patients you recommend it to.
This is the thing. This is new data and it's
Yeah.
not yet in guidelines. And so the American Academy of Pediatrics is, the way I mentioned in 2019, they had a report. They're
Mhm.
updating that ultimately. I bet
Okay.
you they're going to mention these studies in that, and they're probably going to say, pay attention to these trends, but we don't have enough data yet to turn it into guidelines. But this is
Okay.
going to be where we should be paying attention to the formula given to babies in the newborn nursery. And just knowing those two studies, right? The first one, SPADE, is a randomized controlled trial. That's the one that they gave at least 10 cc's daily of
Hmm.
cow milk based formula and kept it in the kids' diet, and that showed protective effects. Where the other one was in the newborn period, where they had willy-nilly or intermittent cow milk based formula that seemed to cause risk. So it makes sense when you think about it, right?
Yeah.
Like a little bit of a false start. So this is just where this is early data,
Hmm.
seeing the trend and thinking about what makes sense. And so this might be a conversation with the team where pay attention, ask parents what their intent is. Are they planning to keep it going? Do they only want a once and done? And then that might be where talking with the newborn team and you guys all coming up with what your local approach will be to that. But I
So if
think
you have,
it's easy to say, please don't make it willy-nilly based on what samples are available. And please
right.
communicate with the families and share what you do know and some of the uncertainty of it, but let them be part of the choice.
Yeah. If you see like a 4-month-old who has a peanut, I mean, I know that's very early, but if you see a young infant with another allergy who's exclusively breastfed, do you typically recommend that the parents introduce like a small amount of cow's milk formula daily?
I have not been. I recommend that the family thinks about early introduction of yogurt,
Okay.
right? So like I'm not necessarily going younger than the complementary solids. And so
Okay.
if there's a family that wants to go exclusive breastfeeding, then my recommendation is going to be, oh, and this is kind of just one thing that might be useful. When I'm talking to a family about introduction, I kind of lay out some general ground rules. I say no honey until after age 1, no added salt and sugar to reason, no loose nuts or seeds until after age 5, no like unpasteurized things that can cause foodborne illness, no raw fish or shellfish, um, no high mercury fish. Otherwise, I say, think about the foods that the family really enjoys eating. Remember my like grandma and cashews example. So think about the foods that everybody likes eating and think about your pets. 40% of dog food has egg in it. Lots of dogs like peanut treats. And think about what the pets are eating, what the siblings are eating, what the people handling baby skin are eating. And then think about those rules. And then think about adding the foods that the family really enjoys eating. What are the foods that bring the family joy? If there's certain foods that they think are revolting, you may not push those where the others that they really like to eat, you do want to push. So then that's kind of where, and then I think of the allergens. So I don't want the allergens at the end of the list. I
Hmm.
want something like cow milk yogurt to be earlier up there because lots of people, dairy is ubiquitous in the houses.
Yeah.
But I'm not necessarily going to recommend cow milk based formula to try to get it in there before the decision to stop exclusive breastfeeding. So I don't include that yet because I don't think the data's there yet. But
Okay.
I do like people knowing what they're getting themselves into in the well baby nursery with a little
Yeah.
dehydrated kid.
Yeah. Okay. Thank you so much. That was so interesting.
Thanks.
Yeah, this definitely very enlightening. Anybody else?
Yeah, so can you just go back over that? You're talking about a baby that just intermittently gets fed formula and then is more exclusively breastfed. Is that where the problem lies?
Oh, I think that, I mean, so again, it's only these two studies, right? And so we don't have like more than that. The problem probably lies once you add an introduction. So, all right, let me bring it back to the LEAP study. So, the LEAP study, they showed that 2 grams of peanut protein 3 times a week was really protective. Now, that's a lot when you're thinking about a kid between the age of 4 and 11 months of life,
Mhm.
right? But when they set up the study, my guess is they were like, go big or go home.
Yeah.
So they found that it really was effective. But now remember the EAT trial that I mentioned briefly, and I said, don't try this at home. These were 3-month-olds, they were very young. But in the EAT trial, they found that when the kids could get to 2 grams of peanut protein, or 2 grams of egg protein weekly, and keep it in, then that was protective. So we're not talking about a once and done when we're talking about allergen introduction. We're talking about getting it in there in a meaningful way. About 2 grams probably is about what we're shooting for most things. And in the case of something that's ubiquitous like eggs or dairy, I've been recommending like a minimum of like 3 to 5 times a week. Something like 3 to 5 times a week. Something like tree nuts twice a week. Peanut, we have the guidelines that say 3 times a week. Fish and shellfish. Now, does anybody know people who eat shrimp like this? Right? So fish and shellfish, there's a lot more hand hygiene. You don't walk around your house with a smelly fish or shellfish to have fish proteins everywhere. There's going to be some families that are like taking it down. But for the most part, who gives their baby fish or shellfish the same, like salmon, like 3 times a week? No. So that's where that one is probably once a week, once every other week in some cases, but again, routinely. So
Okay.
you're not going to want to have a false start. Start shrimp and stop and never give it to the baby again. And then back to this concept of the cow milk based formula in the newborn setting, same deal. If you're going to start with cow milk based, keep it going.
Mm.
If you're going to start and stop, then think about an extensively hydrolyzed formula in its place.
Okay.
But that's not guideline. That's just
Yeah.
me using the currently available data. And before I would ever say that to someone, I would make sure they understand how weak the data is. And then we would talk through it and share decision making because there is ambiguity.
Yeah, I just think a lot, where we are, we see so much cow protein, the milk protein allergy with the blood in the stool. And I worked in allergy before this, so then coming and seeing the new ones with this, I'm like, what is this? And then you go off the milk, and then I'm like, is this going to
And
put them at risk later on? How does it
that's
work?
different conversation also.
Okay.
So proctocolitis. So in the babies who are like happy babies growing, thriving, blood in their stool. Now the problem is that that's a scary experience for many families. And sometimes what's going to happen is that happens and they delay introduction of the other foods. And
Hmm.
so babies with cow milk proctocolitis are at higher risk of other allergies, but some of it might be that delay and behavior, right? And so you'll want to continue the kids to be introducing foods, not stop. And then if there is a pause for whatever reason, then thinking about the skin exposure, thinking about the fact that that kid can continue to be sensitized. And now let's also now have the conversation about dairy. So now we know that that kid is just like a bloody mess whenever they add any dairy into the diet. So it is out, right? But now big brother, mom, dad, grandpa, they're all having like milkshakes all over the place and dairies all over. That kid may then get sensitized and develop IgE mediated dairy allergy, right?
Hmm.
So think about in the kid who does have proctocolitis and you just got to pull it out, or FPIES,
Hmm.
with the chance that they're then going to outgrow it later, thinking about preventing the sensitization further and getting the show on the road as far as the other foods, allergens is going to be important.
Okay. So from a nursing standpoint, teaching like hand hygiene, not to be paranoid about it, but to wash your hands after you eat, allergenic foods before you touch your baby or put the lotion on is probably very
Yeah.
helpful.
So be warned, in the beginning, when I started like giving this advice to families, I think I might have made a little bit of OCD.
I know. That's what
You
I was
know,
worried
when
about. Yeah. Yes.
right? So think about how you say it. So when
Yes.
I'm talking to a family about this, I say, constant routine exposure to allergen on the baby's skin likely sets them up to develop an allergy. Notice I didn't say exposure on the baby's skin sets them up. It's terrifying to think that a
Yes.
once and done might do it. But I think that it's really again and again and again and again and again the patterns of grandma eating cashews and changing the diaper again and again. And so that's where I try to use words like routine, constant, and then I try to take the pressure off a little bit in my language. But the easy thing is if you eat an allergen, before you apply lotions or creams or handle your baby's skin, wash your hands. That's kind of good hand hygiene anyway.
Mm-hmm.
Thank you.
But what you don't want them to do is just keep washing their hands all day
Right.
long.
Right.
And
Exactly.
then nobody's holding the baby.
That's terrible.
Thank you so much for this. I know we're at 9 p.m. Eastern time, so I don't want to hold people and Dr. Pistiner beyond.
Oh, just saying, I'll stay on until you guys pass out. So don't get off on account of me. So like you guys, whoever's got to go, you could go, but I'm happy to stay.
Thank you so much. I'm going to stop the recording, and if we want to whoever wants to stick around and chat a little longer, feel free to do so.